Corneal crosslinking in thin corneas.
Keratoconus is a progressive ectatic disease of the cornea, characterized by stromal thinning, often leading to visual impairment. Of all the modalities available in the management of keratoconus, corneal collagen crosslinking is the only one which can hinder or halt the progression of the disease. In 2003, Wolensock et al. Worked on a prospective randomized controlled trial in the University of Dresden, coming up with a conventional CXL or Dresden protocol as we know it. So in the Dresden protocol, the corneal epithelium is debrided, followed by riboflavin application. UVA light, 370 nanometers in wavelength, is given at 3 mW per centimeter square for 30 minutes. But in the same year, the same group led by Wolensock realized that this procedure came with its own set of limitations. Using the Lambert-Beer equation, they came to the conclusion the cytotoxic endothelial UVA irradiance of 0.35 mW per centimeter square was reached at 400 microns. So this poses a problem. Keratoconus is inherently a progressive ectatic disease with progression seen in 25 to 30% cases and nearly 25% patients presenting with a pachymetry less than 400 microns. Hence, for nearly a quarter of patients with keratoconus, conventional CXL cannot be used as an option. Most of these patients are young, with active hobbies, professional activities, and an entire lifetime to look forward to. So a number of solutions have been devised to circumvent these problems of cross-linking in thin corneas. The first among these is hypoosmolar CXL. While in conventional CXL, riboflavin is used with 20% dextran, which makes it isotonic, hypoosmolar riboflavin is generated by diluting it with physiological salt solution and not using dextran. When in such a solution, the stroma can nearly double in thickness, and Hafeze et al. Used this very property. Hypoosmolar riboflavin was instilled every 20 seconds till the thickness increased to a minimum of 400 microns. A number of studies were conducted, all of which showed stable topography at varying follow-up visits. But this procedure too came with its own set of limitations. The same collagen lakes, which helped increase the stromal thickness, also dilute the number of collagen fibrils available for CXL. The amount of oxygen diffusing through the hydrated stroma also decreases, thereby reducing the efficacy of the procedure. So another way of performing CXL in advanced keratoconus is the transepithelial crosslinking or the epi-on technique. The epi-on technique has shown to result in greater patient comfort, reduced risk of infective keratitis, and decreased incidence of stromal haze post-CXL. The obvious problem is that riboflavin, being a macromolecule, cannot penetrate an intact epithelium. The solution to this is the use of permeability enhancers like benzalkonium chloride and EDTA, which loosen the epithelium, allowing penetrance. The second limitation is that apart from impeding oxygen diffusion, the epithelium itself soaks riboflavin, resulting in its reduced stromal concentration. Wolensock et al. Showed that biomechanical rigidity increased by only 64% after epi-on CXL, compared to a whopping 320% after the Dresden protocol. But enhancers aren't the only way to penetrate an intact epithelium. Iontophoresis utilizes a small electric current to facilitate penetration of an ionized substance across the epithelium. Riboflavin is an ideal molecule for this procedure since it is negatively charged, is water soluble, and has a low molecular weight. The anode is placed on the cervical vertebrae or the patient's forehead, and the cathode is applied to the cornea via a suction ring, and a current of 1 mA is given for 5 minutes. Mastro-Pasqua et al. Showed that transepithelial iontophoresis allowed greater riboflavin penetration compared to the conventional epi-on technique. Most studies showed stable results, with Juve et al. Reporting a 20% failure rate at the 24-month follow-up. The limitations of this procedure resemble those of the conventional epi-on technique. The literature is also sparse, necessitating long-term studies to establish its efficacy and safety. In 2009, Kimionis et al. Came up with the idea that instead of debriding the entire epithelium, a customized debridement sparing the epithelium over the cone of the keratoconic cornea can be carried out. While this intact island of epithelium protects the thinnest part of the cornea, the debrided area elsewhere allows increased riboflavin penetration and adequate stromal concentration, resulting in increased biomechanical rigidity. While Quinones et al. And Mazzotta et al. Showed a stable topography, Cagle et al. In 2017 reported a significant endothelial cell loss. The efficacy of this procedure is not yet established, since there is a paucity of studies reporting the outcomes of the same. In 2014, Jacob et al. Had the innovative idea of a contact lens-assisted CXL. With a thickness of 90 microns, a contact lens can contribute to the overall thickness of the stroma. In their pilot study of 14 eyes, a BCL or a bandage contact lens was soaked in 0.1% riboflavin for 30 minutes. UVA was given as per the conventional CXL, and all their patients showed a stable topography at the 6-month follow-up. The major limitations include decreased oxygen diffusion and riboflavin concentration in the stroma. In the next year, Sachdev et al. Came up with a rather unique idea of a tailored stromal expansion using the lenticule extracted from patients undergoing small incision lenticule extraction or SMILE for myopic correction. The advantages of this procedure are that the lenticule thickness can be customized as per the patient, and the tissue is biologically similar to the patient's cornea. While this modification was found to be safe and effective in their initial study, it requires long-term trials to establish its safety and efficacy. In 2021, Hafezi and Kling came up with an ingenious solution to resolve this enigma. Instead of attempting to augment the thickness of a thin corneal stroma, why don't we modify the amount of UV light utilized in the procedure? This sub-400 nomogram was devised by estimating the diffusion of riboflavin and oxygen by the fixed diffusion law and ultraviolet energy by the Lambert-Beer equation. They then arrived at this really complicated looking formula, the simplified clinical translation of which is this table, which clearly outlines the treatment times required as per the existing pachymetry values. The obvious advantages are that this procedure can be highly individualized and is independent of the swelling properties of the cornea. The group demonstrated a 90% success rate, allowing for CXL of corneas with a stroma as thin as 214 microns. In summary, there exist innumerable modifications that allow for cross-linking in thin corneas, and long-term trials evaluating their safety and efficacy is perhaps the need of the hour.